Hello, everybody. Today's April 19th, 2024. My name is Dr. Kenneth Candido, and I'm privileged to speak today at the Georgia Society of Interventional Pain Physicians, or GSIPP's 20th annual pain interventional meeting. I've been here several times, and I'm privileged to have been invited back by Dr. David Gale, who's the meeting chairperson. And Dr. Gale has asked me to discuss two topics, two distinct or disparate topics, one on spinal cord stimulation, including the economics of spinal cord stimulation and the data which supports our use of neuromodulation for our respective patients. And then the second topic, which will be somewhat briefer and probably more entertaining, is about regenerative medicine in the island of Antigua, where I practice as part of the Prodromos Stem Cell Institute. And I'll go in and describe the types of patients we see, the types of therapies we provide, and perhaps this may have some benefit to you in your own respective practices for the future, in the case that you might want to send patients to us or come down and visit us for determining whether or not this would be useful for your practices. I have no disclosures and no conflicts of interest relevant to these two presentations. I serve as a professor of clinical anesthesia and surgery at the University of Illinois College of Medicine in Chicago. I'm a former program director of two distinct pain fellowships in the Chicagoland area, and I was also a chairman of an anesthesia department for 14 years up until 2021. Presently, I'm the director of pain management services at a place called Thorek Memorial Hospital in Chicago, and I also maintain clinical privileges at several local institutions where I run acute pain services and where I perform higher-end interventional therapies. There are some sobering statistics in American healthcare. I think many of us are aware of that. The most glaring, I think, is the fact that healthcare is a $3.6 trillion industry in the United States of America. What many people don't realize is that chronic pain management is approximately 1/6 of that, or about $600 billion. So 16.7% of all dollars spent on healthcare go to chronic pain management. But what's also sobering and enlightening at the same time is that salaries for chief operating officers of many of the commonly known healthcare insurance companies is upwards of $20 million per year. And so when you think about it, not only is that outrageous in many regards, also the individuals who are not charged with direct patient care, who are not putting themselves on the front lines, who are not sustaining any risks when it comes to managing individual patients on a day-to-day or week-to-week basis, are those who are gaining the greatest advantage economically for healthcare. You can also see that healthcare spending on administration makes up about 73 cents out of every dollar, whereas payment and remuneration to physicians is only about 8 cents on a dollar. So it's kind of like a pyramid that's been turned upside down on its top, with a smaller percentage of individuals gaining a much greater proportion of the revenue, and those who are toiling in the fields, if you will, and subjecting themselves to risks, both health risks as well as stress risks, as well as liability risks, are those who are receiving a much smaller piece of that pyramid or that puzzle. Now, a wonderful paper which was recently published last year in the journal Regional Anesthesia Pain Medicine by my dear colleague and distinguished friend, who is the president of the American Society of Regional Anesthesia, that's Dr. David Provenzano, along with Dr. Jared Heller, looked at some of the economics of spinal cord stimulation. And I encourage all of you in the audience here today to avail yourself of this document and to look at the references attached to it. And Provenzano and Heller looked at approximately 19 studies referencing the economics of spinal cord stimulation, as well as things like side effects, complications, and so forth. And it's a nice paper called Daring Discourse, The Economics of Neuromodulation for the Treatment of Persistent Spinal Pain Syndrome, also known as failed back surgery syndrome or post-laminectomy syndrome, as well as complex regional pain syndrome type 1 and type 2. What the authors pointed out was that there was an audit from the Office of the Inspector General, which found that the use of spinal cord stimulators had gone up 175% between 2007 and 2018, which is a vast increase in the utilization of this type of service over an 11-year period. Furthermore, they found that somehow Medicare had paid or overpaid more than $636 million for spinal cord stimulation during that time period. Now, that's a smaller percentage compared to 600 billion spent yearly on chronic pain management, and an even smaller number when we take into consideration $3.6 trillion spent yearly on American healthcare, but it's still a very substantial sum of money, obviously. And so what the authors were hoping to point out was that spinal cord stimulation is reliable, that there is cost effectiveness data to support the use of this therapy, especially when spinal cord stimulators are used with appropriate patient selection and in compliance with guideline recommendations, therefore, or thereby mitigating patient-related complications. Also pointed out, as I previously indicated, that healthcare expenditures in this country is in excess of $600 billion per year for chronic pain management. Now, there are several barriers for why we have denials occasionally in terms of getting approval for the use of neuromodulation for our respective patients. And some of that has to do with the decision makers' knowledge. And by decision makers, we're talking about insurance companies. Now, we know as physicians that nobody knows more about patients than we do, that nobody knows more about disease states than we do, and that nobody knows more about treatment options than we do. Nevertheless, insurance companies use algorithms to determine suitability of remuneration or payment for services. And those are many times flawed algorithms and flawed paradigms. And so it's a good thought process. In fact, it's our duty to educate the insurance companies. And in looking at references like the Provenzano-Heller paper, we have the capacity to educate the insurers and to help them to see why we believe our patients are suitable candidates for neuromodulation, especially, but not exclusively, with conditions like chronic persistent spinal pain or complex regional pain syndrome. We also have a duty to communicate this information to the insurance companies, and we have to base our fundamental arguments on the credibility of the model. And in doing so, Provenzano and Heller talked about the 5 types of economic evaluations that go into these analyses and the 19 studies which they have referenced in this 2023 paper. And those evaluations include things like cost minimization analysis, also known as CMA, cost benefit analysis, CBA, cost effectiveness analysis, cost utility analysis, and cost consequence analysis. The most common types of methodologies utilized are the cost effectiveness analysis and the cost utility analysis. And we'll look briefly at several of these studies and how they may influence insurers' determinations about whether your patient or your client is a suitable candidate for neuromodulation. Also important to recognize that in cost effectiveness analysis, we have certain outcomes, just as we do with cost utility analysis. For cost effectiveness analysis, the outcome is expressed as a single natural or disease specific unit. For example, life years saved. Whereas with cost utility analysis, the outcomes are expressed as QALYS, also known as quality adjusted life years, for example. There's also a ratio. That ratio is known as the incremental cost effectiveness ratio, where we look at the difference in costs, or the delta C, and divide it by delta E, which is the difference in incremental effectiveness. So obviously, as effectiveness goes up, the ratio goes down. And that's an important concept to understand when you're trying to navigate the murky waters of the decision-making process with insurance companies. However, with the implementation of these newer technologies that we have, including longer battery life, less risk of explantation, for example, improved patient selection and stimulation parameters, we expect that in the future we should be able to pursue having a greater influence on the number and types of patients who have access to neuromodulation. Don't forget that there's also a concept known as willingness to pay. That's a threshold unique to every insurance company, and we don't always have access. In fact, we're almost never privy to that decision-making process about what goes into their willingness to pay, even when one treatment option leads to better patient outcomes. However, it may be more expensive. We don't know what the insurance company believes to be their willingness to pay. Now, if you look at economic models of neuromodulation and the cost evaluation studies, we've been studying this for 27 or more years. The first paper comes out in 97 by Bell, and found that on average, spinal cord stimulator was cost saving on an average 3.3 years sooner in patients who have clinically efficacious stimulation. And obviously they emphasized a golden rule, which still is employed today, that proper patient selection is emphasized. Other studies, Budd, Kemmler, and Kumar, famous studies on neuromodulation and economics, and the types of analyses are on the left-hand corner of this slide, cost minimization analyses, cost effectiveness analyses in many cases, you'll see that spinal cord stimulator was found in almost all of these cases. In fact, according to Provenzano and Heller, 18 out of 19 cases showed benefit from a cost analysis when neuromodulation was implemented for our patients with either failed back surgery syndrome or complex regional pain syndrome. The one study which was a little bit concerning was the failure to derive benefit study of Hollingworth. And that's about 13 years old already. And that was in the workman's compensation model. And regrettably, there have been those studies that I'm aware of which have offset this. And in that study, they looked at costs and cost effectiveness of spinal cord stimulation for failed back surgery syndrome in a population of workman's compensation patients. And they found, unfortunately, that the higher cost of spinal cord stimulation use was not counterbalanced by lower cost of subsequent care over the ensuing 2 years. So this is interesting. It's regrettable. It's not surprising necessarily, because we know that there are many times secondary gain issues with workman's compensation population, not always, but in many cases by nature of the fact that someone's injured in the workplace and they're seeking compensation, hence the term workman's compensation. Pardon me. And so we have to consider going forward having studies which potentially could show a greater benefit in this unique patient population. But the studies of Simpson, Kemmler, Taylor, Kumar, Zuko, Farber, Deloitte, and McHale do show cost benefit of neuromodulation. Finally, we have studies of Taylor, most recently in 2020, showing a cost benefit of using high frequency neuromodulation compared to low frequency spinal cord stimulation. And a very important study by Rojo and Associates published 3 years ago about almost 50% reduction in opioid consumption at the 2-year mark for patients who had spinal cord stimulation. So these are the important studies. 18 out of 19 show relative benefit for the use of neuromodulation for the management of chronic pain of a failed back surgery syndrome and or complex regional pain syndrome type 1 or type 2. Now, there are some key assumptions when we look at this data. And one of the assumptions is, for example, that there are no complications associated with conventional medical management. We know that that's not true. Patients die from opioid overdoses, for example. They have severe morbidity and mortality from other procedures, including surgery, that are performed on their behalf in lieu of the use of neuromodulation. So making that type of an assessment or an assumption can be fraught with failure. We also have to not understand the willingness to pay threshold, although that's included in several of the models that we've just reviewed. Other things like the success rate being greater than equal to 50%, that was studied by most models. Life expectancy was not studied by most of these models of these 19 studies. The longevity of the implantable pulse generator is an important concept. Complication rates, time horizon, explant rate. And I'll show you some new data which shows that between 2017 and 2023, with Rick Rauch's work, for example, that the explant rate has gone down from 7.9% down to about 1.1%. So that's very reassuring going forward. Now, again, Provenzano and Heller found that in the workman's compensation pool of individuals, or in that subgroup of patients who were studied using neuromodulation, that there may be poor treatment outcomes. And that's not necessarily something which is unexpected. Again, secondary gain issues may influence an individual's willingness to, or responsiveness to the therapy, or their willingness to go back into the work environment and to incur ongoing larger costs related to healthcare and pain management. So careful consideration of the patient characteristics, the type of disease, the risk factors associated with poor treatment outcomes need to be reconciled when we make decisions and determinations about who to offer our neuromodulation therapies to. Now, I'm frequently asked by insurance companies, what is the average cost of an implant? And obviously there's great variation between companies, and also, again, respectfully, with regard to insurance companies, what their willingness to pay is. But by and large, for Medicare, if we're considering a 2-lead system with one implantable pulse generator, each lead costing about $4,500 and the pulse generator about $24,000, you can return back to your insurer and tell them that, at least in a Medicare population, we know that the cost of the implantation is approximately $33,566 based upon most recent data that we have available to us at this time. So what are the key value drivers in the health system perspective? One of the most important features is that we're seeing a lot of studies more recently in the last 10 years or less that indicate higher response levels than the so-called cutoff benchmark of 50%, which was the acceptable rate of cutoff for determining success with a trial of spinal cord stimulation. We expected patients to have no less than a 50% improvement in their pain scores without regard to their improvement in functionality necessarily, and without regard to their reduction in consumption of medications necessarily. So let's look at this. This is a very busy slide, and I don't expect to go through it in great detail, except to say that if you go back starting at 2007 to 2023, so we're looking at a 16-year period here, and I highlighted one of Dr. Capirel's landmark studies on the use of high-frequency stimulation because he's here in the audience, and we are appreciative of Dr. Capirel's seminal work on the use of neuromodulation, both for economic reasons as well as looking at efficacy across the board. But you can see that we have overwhelming clinical evidence in favor of spinal cord stimulation, and we have new novel waveforms and platforms that are consistently achieving 80% reduction in pain. So I encourage you to look at the studies, the PROCO RCT, the Sunburst RCT, demonstrating efficacy of conventional spinal cord stimulator use and the superiority of the Burst DR system, the Whisper RCT by North, McHale's CLSCS study with a 79% responder rate, the Fishman RCT showing high levels of success, Wallace with the combo RCT showing 84 and 85% at the 1 and 2 year follow-up marks with a high level of functional improvement in terms of spinal cord stimulation, demonstrating responder rates. It's an enormously high number and much higher than things that we've seen in the past. Then we have Peterson also in the 2021-2022 area for diabetic neuropathy showing a 90% responder rate. These are phenomenal outcomes with careful patient selection, and I'm going to go through that with you, that selection process in a few moments. The ROUC study, the Relief Registry, all important. The Evoke RCT of McHale. You should familiarize yourself with these seminal works in order to have a coherent discussion with your insurer determining the suitability of your own respective patients for neuromodulation. I indicated or alluded to the fact that we've had a reduction in the explant rate recently, and Van Byten and Associates talked about this in 2017, where they looked at a registry with almost 1,000 patients and found explant rates for inadequate pain relief of 4.2%, which is now down to 1.1%. And in Van Byten's study, they had an overall explant rate of almost 8%. Then ROUC came along 6 years later, looking at a relief registry of almost 1,300 patients with 79 centers globally represented, and found that the annualized explant rate was down to 1.1% for inadequate pain relief. So this shows that we're doing a better job of keeping our devices in our patients for a longer period of time. Finnerup and others have looked at the number needed to treat, which is how many patients do you have to expose to a certain treatment, whether it's a medicinal or a therapeutic intervention, in order to have one person improve. This was published by Bussey et al. In the Journal of the American Medical Association in 2018. It was a meta-analysis of 96 randomized trials. And if you look at the number needed to treat with spinal cord stimulation, it's a mere 3.0. So you expose 3 patients to this therapy, and for 50% or greater improvement, you'll have at least one patient who's improving. Compare that to tricyclics, where the number needed to treat is 3.6. So it's higher, meaning not as efficient or effective. How about strong opioids, 4.3, not as efficient, not as effective. Tramadol, 4.3, not as efficient, not as effective. SNRIs, all the way up to 6.4 patients, number needed to treat, not as efficient, not as effective. Gabapentinoids, 7.2 to 7.4, and capsaicin is almost off the board at 10.6. So we see that there is data available indicating the superiority in terms of numbers needed to treat for the use of neuromodulation. Very important publication from the United States Department of Health and Human Services, looking at national coverage determinations, 160.7, which provides coverage that meet the criteria for the use of spinal cord stimulation. I encourage all of you to avail yourself of this readily available document. It talks about multidisciplinary and multimodal approaches to managing chronic intractable pain, failed medical management and conservative care, and that the use of spinal cord stimulator is favorable in terms of reduction in opioid use. And I talked to you about that a few moments ago, as well as an upcoming paper by Chris Gilligan, which was presented at the NANS meeting this past January of 2024. I'll talk about that momentarily. So this is a readily available document. Learn about NCD 160.7. You can Google search it or look at the United States Government Department of Health and Human Services and download this document. So what are the spinal cord stimulator key value drivers from a health system perspective? Let's talk about outcomes research. I already talked about some of this. There were a 14 review of health effective outcome research studies using the CHEERS analysis for failed back surgery syndrome and CRPS 1 and 2, as well as diabetic peripheral neuropathy, peripheral vascular disease. And the conclusion of these 14 reviews was that spinal cord stimulator use is cost-effective therapy when we consider long-term treatment for patients with neuropathic pain, that is from failed spine surgery and CRPS. We don't necessarily have hard data for the use of ischemic pain because we have a lack of data. And so we've got to go and try to recruit more patients for more of these studies. But it's overall very much favorable for the use of spinal cord stimulation. Back to the Provenzano and Heller paper again from 2023, Regional Anesthesia Pain Medicine. They concluded after looking at this through their review that 18 out of the 19 studies cited were favorable generally for the use of spinal cord stimulation from an economic perspective, but that careful consideration of patient characteristics, the type of disease, and the risk factors, including workman's compensation, associated with poor treatment outcomes and an increased economic burden, again, workman's compensation patients must be thoroughly reviewed when considering who's a suitable patient for neuromodulation therapy. Recent papers from Patel in 2022 looked at non-surgical back pain patients. So these are not patients who've had surgery. They don't have a diagnosis of failed back surgery syndrome or post-laminectomy syndrome. 159 patients randomized 1-to-1 stimulation versus conventional medical management. And the authors, Patel and Associates, found that spinal cord stimulator use for non-surgical back pain was cost-effective compared to conventional medical management at a 2.1-year period. Now we have Raj Kumar, who's had 2 beautiful studies published in 2022. These are all recent papers that I'm citing, by the way, for non-surgical back pain, 119 patients, again, randomized, and found that spinal cord stimulator use may be associated with a significant decrease in total healthcare costs, offsetting the device acquisition costs at 27 months. So we saw 2.1 years here with the Patel data. Now we're seeing 2 years and 3 months here with the Raj Kumar data, very similar for non-surgical back pain, very consistent that at about 2 years or 2 years and a little bit, we're having the break-even point from an economic perspective, from a cost perspective with the use of neuromodulation versus conventional medical management. The second paper published by this same group of Raj Kumar and Associates was on diabetic peripheral neuropathic pain. Here they looked at 132 patients, so a little bit of a larger study, and they found that cost recoupment when neuromodulation, spinal cord stimulation was utilized was at 3.5 years. So it's a different disease model, a little bit more resistant to treatment, still requiring some medical management of a fairly aggressive nature to manage patients, and not unlike their prior study with non-surgical back pain, but now the time to recoup that money was a little bit delayed on the order of about 3.5 years. Very important paper published or in the process of being published right now, presented by Chris Gilligan and Associates at the NANS meeting 2024 January, looking at a large subset of patients, almost 2,300 patients who underwent neuromodulation. And what they found is very reassuring data that 60% of patients were able to discontinue or significantly reduce their consumption of opioids following implantation of spinal cord stimulation. So that's a phenomenal outcome. That's something which I believe insurers will be extremely interested in looking at. But not only did they find reduction in opioid consumption, Gilligan and his associates found that benzodiazepine use in the neuromodulation groups was reduced from 47.3% to 30.3% at 3 years. And also, even the use of drugs like gabapentin went down from 58.6 to 42.2, very reassuring. Not only that, but polypharmacy was reduced from 15.6 to 9.6. So this is all very strong data in favor of the benefits of neuromodulation, not just subjective reporting of pain. Obviously, that's flavored by patient expectations and knowledge, education, how the physician perhaps even coaches the patient. This is objective evidence now that neuromodulation improves pain and improves and reduces patients' pharmacological requirements to manage their pain conditions. So if you're going to seek to have approval with a requisition for a spinal cord stimulation use, you should be able to document very carefully in the patient's record that they've tried pharmacological therapy and that perhaps they've had either intolerable side effects or lack of efficacy from using commonly used pharmacological therapies. They've also tried conservative medical management, including physical therapy, including epidural injections, other interventions like facet joint or medial branch injections, radiofrequency neurotomy, for example, that you've been able to identify that and rule out extra spinal causes for an individual's respective pain, and a specific spinal etiology is the source of pain. Sometimes that involves the use of recruiting some of your colleagues and seeking out consultation, for example, with our neurosurgical consultants to make a direct diagnosis in the chart that this patient has spinal disease, but they are not a reliable candidate for conventional orthopedic or neurological spine surgery. And if the surgeon, the orthopedic surgeon or the neurological surgeon goes on the record and says, hey, I think this patient's a very strong candidate for neuromodulation that may help influence the insurers when they make their determination on behalf of your patients. Also ruling out significant psychological impairments, things like severe anxiety or depression, also demonstrated and documenting no less than at least 50% improvement subjectively in pain reporting by the use of the neuromodulation trial. Now, the newer indications up and coming on the horizon and presently actually for the use of neuromodulation include things like diabetic peripheral neuropathy related pain. So it's important that you document that the patient's had at least 12 months of ongoing lower extremity pain, for example, that's rated no less than 5 out of 10 on a numeric rating scale, where 0 is no pain, 1 to 3 equals mild pain, 4 to 7 or 4 to 6 is moderate levels of pain, and then 8, 9, and 10 is severe levels of pain. You should also get a second opinion from somebody who has no skin in the game, their internist, their family practitioner, for example, to document that they do in fact have limb pain related to their diabetes. Also for non-surgical back pain, another up and coming newer indication. Consider surgical consultation. It's very important for a surgeon to document that yes, they have spondylosis. Yes, they perhaps have degenerative disc disease, intervertebral disc disruption, severe spondylolisthesis that's not a surgical option at that time for that patient. And have the neurosurgeon or the orthopedic surgeon document that. That may be favorable documentation on your behalf and on behalf of your patients. And of course, use the US West Street Disability Index. Sometimes that has a favorable impact upon insurers' decision making. Now, when you have all the proper documentation, you can expect that in about 90% of cases, you're going to get authorization for the use of neuromodulation. And in the 10% of times that you don't do that, only 34% of us are going back and trying to appeal that negative or adverse decision. What happens to the other 2/3 of patients? Well, I suppose clinicians are medically managing them using opioids, gabapentin, muscle relaxers, physical therapy, and injections. And that's regrettable because if you go back and see what's being sought by the denial process and the peer review process and the peer-to-peer process, in 70% of the cases where there's an appeal made, we are successful in having approval for third-party payers paying for our individual respective patients. So it's very important to pursue it. Don't let it drop. Don't throw up your hands and say it's a lost cause. Go back and try to fight the negative determination of the insurance company on behalf of your patient. So what's the policy here at GSIPP? I'm recommending for the Georgia Society of Interventional Pain Physicians, ensure proper patient selection, document and support in your medical record and the clinical notes from the practice why you believe neuromodulation is an effective choice for your patient. In fact, is the best choice for your patient, and include letters and documentation from referring physician and outside consultants. Demonstrate interventional pain management value by leveraging FDA-approved technologies with published studies, as I've indicated to you before, and as you have access to by just downloading a copy of the RAPM 2023 publication of Provenzano and Heller. That's a good starting point. And then for a deeper dive, pull up their respective references and look at each of them individually with a discerning eye. Optimize patient and practice experience by incorporating the best practice examples, internal assessments, and operational resources. Here's a partial list of the references that I utilized in preparation of this discussion. I encourage all of you to avail yourself of them and to strengthen your posture and your position. Don't throw your hands up in the face of a denial. If you fight the denial, of which 34% of us are presently doing, there's a 70% likelihood that you'll be successful on the second round. The second part of this discussion will be a brief overview of some of the work we do using regenerative medicine on the island of Antigua, where I currently practice with Dr. Chadwick Prodromos at the Prodromos Stem Cell Institute. You can see the island of Antigua from an airplane view. It's a beautiful island at the bottom of the chain of the Lesser Antilles. It was first identified by a European when Christopher Columbus set sail and landed there in 1493. So about 1 year after he came to North America, he landed in the Caribbean here and found a beautiful harbor known now as the English Harbor, which is one of the deepest water harbors in all of the Caribbean Sea. And you can see it's a pineapple island. It's an island which was historically a sugarcane island. Interestingly, there was slavery on the island until 1837 when it was abolished, in anticipation and way ahead of when slavery was abolished in North America, for example, during the American Civil War. But a lot of individuals stayed and they toiled very vigorously in the sugarcane industry, which was their primary source of income from the gross domestic product, until it was overtaken probably in the 80s by tourism. You can see here the English Harbor and Medical Surgical Associates, where I have one of my offices, where I practice with Dr. Prodromos. You can see me standing on one of the landmark bridges called Devil's Bridge, very dangerous area with beautiful scenery and volcanic rock. And I'm standing in front of one of the older sugarcane mills on the island that you can have access to and have a tour of to learn about the history of this amazing place, a place with 365 beaches, one beach per year. Condé Nast has rated at least one of their beaches as a top 10 destination beach in the entire world. Very peaceful, very quiet place with a lot of interesting people who have residences there. Eric Clapton has a home there that I pass by almost every day when I go to my job. Eric Clapton has a recovery center there called Crossroads, like one of his record albums going way back, where he treats drug addiction and alcoholism. He's apparently very gracious to the people on the island and offers services free of charge to locals who may have that affliction and may need his services. Silvio Berlusconi, the former prime minister of Italy, also has a home. Oprah Winfrey has a home, and many other people. A lot of people who reside in Antigua. Here I am again at the English Harbor, where there's a lot of large cruise ships actually come in, and people have sporting boats and individual pleasure boats. I'm looking out from one of the main beaches. I'm lounging around in a chair, and I'm holding my golden football, which I utilized to throw about a year ago into a basketball hoop from 45 yards, setting the Antiguan national record for the longest football throw into a basketball hoop, 45 yards. I've also set the records in places like Spain. I just set that last week. I set it in France. I set it in Brazil. I set it in Mexico. And I have set it in the United States as well. Hopefully, I'll set it in Prague when I go to the European Society meeting this coming September, and in Italy, which I hope to visit also before the end of the year. This is our team. On the right-hand screen, you'll see Dr. Joseph John, who's the owner of the Clinic of Medical Surgical Associates. And Dr. John is a local Antiguan who established a very successful business there. He's been knighted on the island. He has a very vigorous surgical practice. He trained in the United States in New York City. To my right, on my right shoulder, is Dr. Chadwick Prodromos, who's the founder and the owner of the Prodromos Stem Cell Institute. And I encourage all of you to do a search on him and see the kinds of services that he offers. You'll see one of my fluoroscopy machines, state-of-the-art equipment. We have all state-of-the-art equipment there. It's a very highly functional technical institute. On the left side, you'll see myself standing in front of the practice, and below is Dr. Teresa Kusper, who's one of my former trainees. She's a board-certified anesthesiologist and pain physician who offers tremendous assistance to us in the performance of regenerative medicine on the island, and also sedation services when called upon to do so for individuals who may require sedation for these procedures. We do all these procedures in a state-of-the-art operating theater. You'll see me doing intradiscal injections. Sometimes I do subarachnoid injections for conditions like multiple sclerosis or amyotrophic lateral sclerosis, using human mesenchymal pluripotent stem cells, facet injections, for example, caudal epidural transforaminal injections. And we do this, we've done more than 300 patients and counting to date. And we've had some outstanding results. We're actually publishing our results. This is one of our case reports, the first human report of relief of lumbar and cervical discogenic and arthritic back pain after epidural and facet joint mesenchymal stem cell injection. We have now collected data on more than 100 of our patients who've received spinal interventions. We're preparing a manuscript for publication, and several others, including a publication on the use of these cells for trigeminal neuralgia. I'll talk about that in just one moment. Now, I want to mention a couple of individuals who sought treatment on the island. I can do so because they've gone public with their stories. One is Ryan Jensen, all-pro center, and the last center for Tom Brady at the Tampa Bay Buccaneers, took them to the Super Bowl where they won a Super Bowl. Then, for example, regrettably, Ryan Jensen, who was really in the prime of his career, sustained what some would have considered to be a career threatening injury, at least, when he tore 5 ligaments in his right knee, his partial ACL, his middle collateral ligament, posterior collateral ligament, his medial meniscus, and also had fractured his tibial head and cartilage. And he was told by no less than 5 orthopedic surgeons that he would need a total knee arthroplasty. And he was also told by these same orthopedic surgeons he would likely never play professional football again. Well, he came down to Antigua and he received treatment at the Prodromos Stem Cell Institute. And within 3 months, he was back on the field. He played in Tom Brady's final game, a game that they lost, that Tampa Bay lost to the Dallas Cowboys in the first round of the playoffs in 2023. So he did go back and play. He subsequently sustained yet another injury, and his status is pending. But Ryan has gone on record to testify to the fact that he's had tremendous outcome using pluripotent mesenchymal stem cells for his recovery. Another great player, an individual who's also been a all-pro quarterback, is Kirk Cousins, who previously played for the Minnesota Vikings for 6 years and for Washington before that, and now recently has become the starting quarterback for your Atlanta Falcons here in Atlanta, Georgia. And Kirk is a marvelous human being and a wonderful athlete with tremendous drive for success, who unfortunately in the most recent football season early on, he sustained an injury to his Achilles tendon on the right side. So you can see that he underwent surgery while he was still a member of the Minnesota Vikings. And to hasten his recovery, and again, I'm not violating any laws here because Kirk has gone on record to indicate his tremendous gratitude for the work performed upon him at the Prodromos Stem Cell Institute. He came down twice, actually, last year and then this year in January to undergo stem cell therapy. And according to all reports, he's making a remarkable recovery and should be on the field for your Atlanta Falcons starting for the 2024 season. Finally, one of the things that we do uniquely on the island of Antigua and some of the other places where I provide regenerative medicine services is trigeminal block, a 3-dimensional CT scan guided block using approximately 25 million human stem cells to help individuals who've tried other remedies for trigeminal neuralgia, including microvascular decompression, also known as Janetta's procedure. They've also had other injections by neurosurgeons or interventional radiologists and have failed to derive benefit with steroids. They've failed to derive benefit with the use of either pulsed or conventional radio frequency or cryo treatment. And they come down. We've now taken care of approximately a dozen individuals seeking this type of remedy with some fairly robust results to date. And these images demonstrate on the right a 3-dimensional reconstruction of the needle entering the foramen ovale. Now I do this in about 6 to 7 minutes per case, approximately. Sometimes a little bit longer, sometimes even a little bit quicker. We use obviously a laser to help guide the direction of the needle. We're the only place in the entire world offering this type of treatment for patients with chronic, recalcitrant, persistent trigeminal neuralgia. And the arrow points to the needle, which looks like a straw, entering the foramen ovale. We've had no complications, nothing besides a non-sustained transient paresthesia that lasted less than 4 hours in one patient. We've had no significant CSF issues, even though I enter Meckel's cave using this approach. And we've had no individuals who have failed to derive some benefit, at least from the therapy. This is a final rendition looking at both sides with a rotated skull in 3 dimensions using this fantastic CT scan imaging reconstruction showing perfect placement, if I say so, of the needle into the foramen ovale. So I hope that this has been enlightening to you. I hope that this has been something which you'll find to be useful. I hope this is something which you may decide at some point to utilize in your own clinical practice. I would like to take this opportunity to thank the course promoters, especially Dr. David Gale and the Georgia Society of Interventional Pain Physicians for inviting me yet to another fantastic meeting. This, the 20th anniversary of GSIPP. Thank you. Have a wonderful day and a wonderful meeting.